Cancer permanently changes your life and your loved ones' lives. If the diagnosis is already psychologically devastating, the treatments, medicalization of life, and managing uncertainty make this disease a torment for millions of people around the world.
In Spain, the statistics are devastating. The 2% increase in cancer incidence is significant.
Gloria, do you think it's a good thing for people to mentally prepare themselves to have cancer?
For what? Let me die in peace. We believe that cancer is already the end.
Today's guest, an oncologist, helps us talk about cancer in a positive way.
I prepare patients for chemotherapy.
How can you go through cancer without letting it take away your life while you're still alive?
It's about making sure that you are the protagonist, not the illness.
A patient who gives up and loses the will to live often hastens their own death.
This isn't tonsillitis because it's going to allow you to keep living while you receive treatment.
What can we do to tolerate treatments as best as possible, to be more mentally resilient, to better support patients and families, to live with this disease inherent to the human condition with dignity? Welcome, better than yesterday, Gloria Marquez, your oncologist with a positive approach. Gloria Marquez, welcome. How are you?
Glad to be here. Thanks for inviting me.
Look, we handled the topic of oncology much better than yesterday. First, because it affects my family and me personally. And second, because I think it's so important to talk about oncology, say it more positively and with less negativity. Well, first, not to talk about cancer as a taboo, but to talk openly and really share what happens to patients and families when there is a diagnosis. So I think that's your main role today, right? That you explain to us why, well, you don't just focus on traditional oncology, which would be diagnosing and treating tumors, but also helping patients regain control of their lives when they receive a diagnosis like this.
I've been practicing oncology for many years, and the way they teach you to practice oncology is to treat the disease, to treat the tumor. But seeing so many people suffer for so long, and even when you have a positive result in the size of the tumor or in the remission of the tumor or in controlling the disease, people are left devastated, exhausted, worn out. It made me think, well, what's going on? Why are people like this? But it wasn't an overnight process. It was more like a drop that keeps falling. And seeing people who were beside themselves during their treatment, because the process is much more complicated than they expect it to be. It made me look for alternatives on how to help the patient, not just treating their illness, but treating the patient. That is, making sure the patient is the protagonist, the patient feels better, and the patient can manage their situation despite all the adversity. So, well, look, I took a diploma course in positive psychology while I was in Venezuela, and that opened up many opportunities for me. Also, my mentor in Venezuela and my medical school were very people-centered, actually touching the patient, examining them, listening to them. So that made me look for options that are studied, that are practiced, that are published, about how to improve the patient's condition during treatment, how to relieve symptoms, how to manage everything related to the treatment, and make that treatment less of a burden.
You've said something very important, and it's that sometimes even if we succeed with the treatment and the tumor shrinks, disappears, and let's say the disease seems to be under control, cancer leaves a psychological mark on patients and families, which sometimes isn't addressed, right? And sometimes this doesn't just last a year or two, sometimes it can last for the rest of a survivor's life, right? Yes, it also needs to be addressed. Gloria, do you think it's positive that people in general nowadays mentally prepare themselves for having cancer? I'm not sure if the question will be understood, but do you think it's positive for us to make the effort to put ourselves in the position of having cancer someday, given that statistics tell us it's more than likely we'll have it?
You're absolutely right. Statistics say that 1 out of every 8 people in the world will have cancer at some point in their lives. In Spain, the statistics are devastating. The 2% increase in cancer incidence is significant, and that's going to keep rising or has already been rising every year. And you're either going to have lung cancer, or you're going to have colorectal cancer, or you're going to have breast cancer. So it's like, wow. Let's think about this. I think every human being should prepare for changes. And illness is a change. And a chronic illness like cancer involves a very significant change. So preparing ourselves in case we have to face a diagnosis of an illness is a benefit. And if it's for cancer, even better. Now, if we start by preparing ourselves, avoiding risk factors, tobacco, avoiding obesity, increasing exercise, improving our intake of healthy foods, that would also be a benefit, but a preventive one. Once you have the diagnosis, that's when it will matter a lot and it will be an absolute benefit. Having cultivated soft skills throughout your life, those are the skills that are used in corporate culture: empathy, resilience, adaptability, positive thinking. You, look, all of that, as long as you have developed it throughout your life or in your adulthood, will be a benefit. Because this is nothing more and nothing less than a change in your life where you have to adapt, you have to be empathetic, even with yourself. You have to be patient, in the sense of waiting with hope, not being passive. I don't agree with that idea at all. So, yes, to your question, my answer is yes, I think we should prepare for it.
Yes, and you should prepare when you're healthy, because when you're destabilized by illness, sometimes you just don't have the resources, energy, or willingness to make changes, like developing all those soft skills you mentioned.
Correct.
Yes, would you say that there are risk factors for different types of cancer that people aren't taking into account and that it would be good for them to remember?
Look, the direct relationship between tobacco and lung cancer or bladder cancer is clearly known. And people hate me for this, but I'm totally anti-tobacco, against anything involving combustion. However, that's the most well-known, but maybe not the most common. Obesity is a very complicated issue, and it has a really, really important connection. Colon cancer, rectal cancer, breast cancer. Sun exposure, which we think is just lying in the sun, but no, it's sun exposure without sunscreen. When you have risk factors, when you have very fair skin, when you've already been diagnosed with some pre-malignant lesions. The consumption of ultra-processed foods. People have no idea about the harm they're doing to themselves with that. Eating quickly, stress, and living life as if it's all here and now and the world is going to end. That has a direct relationship with a constant inflammatory process. Of course, until it's published and becomes an issue like tobacco and bladder cancer or lung cancer, people might not notice it, but I believe that's where things are going.
Yes, definitely. Yes, we're reaching a point where the massive consumption of ultra processed foods is getting closer and closer to tobacco as a risk factor, especially because it's very normalized, very widespread. Correct. We can't say that eating a donut is toxic, but because of the population's consumption pattern, it's becoming an increasingly significant risk factor. Correct. Because in the end, it's totally trivialized. Well, if we eat or have processed meat for a snack, it's considered normal culturally, but it's not. Well, now let's talk about when a patient receives a cancer diagnosis. What are these toxicities? People mention it, but many in the audience may not know what it means.
Okay, when oncologists talk about toxicities, toxic events, or adverse events, they mean effects related to the treatment more than to the cancer diagnosis itself. Sometimes people receive a cancer diagnosis and they are asymptomatic, they have a lesion and haven't noticed it, or the symptoms are very vague. But once you start treatment, then the adverse events come, or toxicities related to the treatment. And that's why people have such an aversion to chemotherapy. Of course, let's say that chemotherapy is deadly. I don't want to receive it. I don't even want to imagine it. No, because of course there's also there's also in our Western culture a direct relationship between the word cancer and death. We believe that cancer is already the end, that there's nothing else we can do. And if you also have to give me chemotherapy, well, what's the point? Just let me die in peace. It's not like that. It's not like that. I've been treating cancer patients for 20 years, and I've seen it all. From the third world, and now that I'm in the first world, I've seen it all. So yes, it's true, adverse events have a lot to do with the clinical, emotional, and cognitive deterioration of the patient, but it can be avoided. The adverse event can be minimized, and the consequence of that adverse event can be avoided. Well,
Let's now explain, Gloria, if you agree little by little, the different adverse effects and toxicities that we see. Because people, I don't know, I imagine that someone who hasn't gone through the illness, well, what comes to mind are vomiting and hair loss. Yes, those are the most.
that's the most typical, yes.
But there's much more, and there's a lot more that people don't know about. So, for example, what is mucositis?
Perfect. Mucositis is something that maybe you and I have experienced even without having chemotherapy, which are those canker sores or lesions in the oral mucosa, meaning inside the cheeks or on the tongue or underneath on the palate, whether soft or hard. It has, it has a lot to do with different types of chemotherapy regimens and is more related to chemotherapy regimens combined with radiotherapy, especially in the head and neck areas. Classically, mucositis was studied in this type of patients who have to receive chemotherapy with radiotherapy. However, mucositis has spread to other regimens, to other types of chemotherapy treatments or drugs with chemotherapy, and it is very bothersome. It's very bothersome because it starts with inflammation in the mouth, that is, on the tongue, in the oral mucosa. And that inflammation spreads until sores appear, like the ones teenagers get when they bite themselves or have braces, and they are so bothersome. They are perfectly preventable. I mean, I prefer to stay here so that people remember the information about how negative mucositis is. Yes, it's important to know, and the oncologist explains it to the patient in those treatment regimens that are associated with it. How can you prevent it? You can prevent it by taking precautions before starting chemo, since you'll know whether or not it's related to mucositis. Don't consume alcohol, don't use tobacco, of course, don't eat acidic or spicy foods or foods with garlic or curry. Protecting the entire oral and gastrointestinal mucosa from acid exposure is crucial, as well as using a toothpaste. At least make sure you can verify it. It should not contain, or rather SLS, which is a certain substance, sodium lauryl sulfate, which is used in cosmetics to create more foam or a more soapy effect when brushing your teeth. This irritates the oral mucosa more and prevents the oral mucosa from healing faster. So if you check the back of the toothpaste, you can see if it has SLS and avoid using it. If you are going to start chemotherapy treatments, you are going to have mucositis. Mucositis is so uncomfortable that people stop eating.
Yes, and it also malnourishes the patient, not just causes discomfort. That's why they don't want to eat, because it hurts or bothers them and they become malnourished. And we know that cancer itself causes malnutrition at extremely fast rates.
Well, nowadays what we do is tell the patient, if the treatment regimen is very harmful to the mucosa, to use crushed ice or chew on these popsicles that are frozen during the chemotherapy infusion. That has been proven in some studies that the vasoconstriction, the constriction of the oral mucosa, helps reduce it significantly. That's right. The effect is that the medication doesn't reach that area of the oral mucosa, and that helps a lot. But it's vital that the patient goes to the dentist before starting chemo, so the dentist can check all the teeth, clean, and prepare everything. What happens is that we don't always have time for that, and patients don't always have all this information. Our healthcare system, well, here and in any part of Latin America, can't keep up to provide that kind of approach, but well, let's say that with mucositis, we can try to prevent it this way.
Yes, yes, making a point with many differences, of course. It also reminds me a lot of obesity in my specialty. I mean, most of the diseases we face require a multidisciplinary approach that involves a change in habits and support that our current healthcare systems can't provide. With obesity, if I just prescribe the medication, the GLP-1 analog, and forget about it, we won't get good results. Yes. And I think that in oncology, if we just treat the tumor and that's it, we're really falling short. That's how I feel, you know?
That in the end, totally.
The current systems don't allow for proper treatment because in oncology, you also need psychological support, you need training, nutrition,
The ejercicio,
enfermería,
exercise, nursing.
dentistry, you've mentioned that too. So, well, we need to rethink that.
Absolutely.
And Gloria, something else that people don't know either, cancer patients sleep worse.
They sleep worse. Why? Because there is an adverse event related to, let's see, cancer itself creates an inflammatory state related to cytokines that will affect sleep or the circadian rhythm, cognitive activity, the hypothalamus pituitary adrenal axis. And this means, for example, in the case of sleep, that people have more insomnia, and when treatment begins, this gets worse. There are medications that are more likely to cause insomnia, and there are medications that are less likely to cause it. But it is important that you ask the patient during the oncology consultation how they are sleeping. And prescribing benzodiazepines right away is not what's indicated. Instead, what you should do is investigate further. I repeat, most of the time, there isn't enough time during the consultation, but we have to make an effort to communicate if we are patients. And if we are oncologists, then we should insist. The patient undergoing treatment usually appears not only anxious but also distressed. Their ability to handle uncertainty is not the best. And they go through so many changes that you see they get home and can't sleep. On the other hand, the fatigue during the day makes them take more naps. And at night, then they're not sleepy and they keep going over those repetitive thoughts. Here, the point is first that you avoid ruminating about this, but that can't be achieved by willpower alone. You need, let's see, specialized care. The psycho-oncologist helps a lot here, and so does the oncologist. The nursing team can detect it and work on it. For the patient who can't fall asleep, which is one of the stages of insomnia, one of the ways to address insomnia, whether it's difficulty falling asleep or staying asleep, sleep aids also help a lot. But not benzodiazepines, rather sleep aids. Correct. Sleep aids are very helpful, and that's what we're trying to do. And sleep hygiene, of course, especially at the beginning. Avoiding the use of screens, going to bed at the same time, having a bedtime ritual, making sure the bed is only for sleeping, and avoiding naps during the day.
And on top of that, many oncology patients are on high doses of corticosteroids,
Which is also an excellent point. The corticosteroids that are used, usually dexamethasone, are given in the morning and at night, and that's how they're prescribed to avoid other adverse events related to the chemo regimen. Sometimes we prescribe them the day before. We should tell the patient to take it in the morning and at snack time, not in the morning and at dinner. That is not breakfast and dinner, but breakfast and snack, because otherwise it keeps the patient active and they can't sleep. Of course, or the corticosteroid, or corticosteroid that's used as an adjuvant to help with nausea and vomiting. That is to prevent nausea and vomiting, or the one that's used for anticipatory nausea. Also use it early in the day, not at night.
Gloria, do you think that nowadays, with the rise of AI and all the information we have, do you think this calms patients or makes them much more anxious? You know, because I imagine you get a diagnosis of lung cancer, which is also threatening and so on, and you enter all your data, your lab results, and then AI starts giving you information. Is this good or bad? Because unless you more or less know how to use the tool, the information it gives you is overwhelming. I mean, it's incredible.
It's amazing. If my husband hears, he'll kill me. I support AI. Look, I think AI is a wonderful tool to save time when you have to generate information or content, but you have to use it with a critical mindset. The patient doesn't have a critical mindset because they're not a doctor, so AI, on the other hand, will always give you the answer you want to hear. So if you want to ask and you go to AI, even if you have the best prompt, like, how can I avoid doing this or that? Or what's my life expectancy if I have this type, with this stage, with this mutation? AI will tell you what you want to hear. It's dangerous to use AI in medicine as a patient, not as a doctor, or before that, Google. It's dangerous because the patient will have information that is not reliable, that is not verified, and may latch on to that information. And they will be missing out on other information, which is what will help them improve or what will be effective for them. And the experience generally is not going to be good.
And above all, the state of vulnerability in which you receive that information, right? Because in that state of desperation is when you can start making decisions that aren't the right ones based on information from technology. Correct. For example, taking certain supplements or not getting treatment.
See, that's why it's so important to prepare for chemotherapy. It's so important when I hear patients tell me, Doctor, I want you to prepare me to receive the treatment. I say, you're making the best decision of your life in this process. Because it's going to be crucial for you as a patient to have a better experience, an experience that can help you thrive during chemotherapy treatment. Not that you go resigned like someone who's about to endure a beating. This is not a beating. The treatment is the best resource your oncologist or your medical team has so that you can get out of the chaos the disease has caused in your body and your body can regain control over the disease. Now, preparing yourself is extremely important. It's extremely important because it will allow you to keep living while you receive treatment. This isn't tonsillitis. No, because people go get the prescription, go to the pharmacy, get the medication, take it for 7 days, and after 7 days, that's it. This isn't like that. Nothing works like that in oncology. This is constantly changing. There are always new options. There are always changes. People have their chemo scheduled for a certain day, and it turns out they don't get it that day, but the next day because their hemoglobin was low, or their bilirubin was high, or for whatever reason. So you need to prepare yourself knowing that changes will come and that you can plan your life around the treatment. For example, if you have a treatment that's going to cause certain side effects and you can know when those side effects will peak, on a certain day you can make plans so that once that happens, you can go on with your life. If you play golf or if you play paddle one Thursday a week, then you can do it. If you're a mom with young kids and you want to pick them up from school, you can do it on certain days. But that will help a lot so that, among other things, you don't lose the desire to continue with the treatment.
No, that's a great point. I hadn't thought about the fact that they have to come up with a new plan for their daily routine based on the side effects so they can still have some control over what they can and can't do.
Absolutely. And that can be done. It can be done. I do it with my patients. I give my patients a monthly calendar and we mark things on it. Okay, if you're going to receive this regimen or that other regimen, then we know that from day 3 to 4, you'll have the most. Or when fatigue is at its worst, for example, which is one of the most uncomfortable side effects, that tiredness people feel, but that's going to decrease over time. You also know that you're going to have the nadir of chemotherapy, meaning the lowest point of your white blood cells or platelets over a certain range of days.
Don't attend birthday parties where everyone has a cold.
That's right. On those days, you know that if you go out, you should wear a mask. Don't go to concerts or family gatherings with kids who have runny noses. And if you want to go outside, then go to open places. I mean, you can plan those kinds of things. And that really helps you stick to it. The first, the second, the third, the fourth, and however many cycles are needed. There are people who have a set number of cycles, 4 cycles or 6 cycles, 8 cycles, but there are people who don't. There are people who will be receiving chemotherapy for a long time.
In other words, the treatment can be extended.
Of course, it depends on their stage. If it's already an advanced stage, then what you're looking for is to control the disease and stop its progression. So you're going to keep giving chemotherapy or treatment until, well, you have to switch to another regimen because this one is no longer working for you. So it's about incorporating that into your life, not you adapting to the treatment, or rather the new routine. No, it's about incorporating the new routine into your life. It's about making sure that you are the protagonist, not the illness. Of course, here the patient is the protagonist, not the illness.
Yes, to give the patient a sense of control as much as possible, right?
That's very important. When people lose that sense of control over their lives, wow, they feel really bad, of course.
And you mentioned the psycho-oncologist, the female psycho-oncologist. In your opinion, what is the most important job they have to do with patients?
Well, first, to maintain a close relationship in coordination with the oncologist. The psycho-oncologist is vital to help manage uncertainty, anxiety, and fear throughout this process. Anxiety and fear are minimized, but uncertainty will always be there. Why? It's a perfectly understandable situation in any part of our lives as human beings when we don't have complete certainty about what will happen. So in oncology, there is no certainty about what will happen. And that's why, will they give me chemo today? Will I be ready today? Or will I finish and then they'll operate on me? That's constantly on the patient's mind, and the psycho-oncologist provides tools for that. Besides working on these soft skills, the psycho-oncologist manages the patient's relationship with themselves. There's a lot of guilt in oncology patients.
There's a lot of guilt around cancer.
A lot of guilt. A lot of guilt above all. Look, do you know where there's a lot of guilt? With the patient who smokes and has lung cancer?
Of course, that I can understand.
The obese patient who was warned many times, or the patient who was afraid and didn't go to the doctor in time, or the patient, well, we could be here all afternoon. And it's normal because when you're very hard on yourself, you start thinking, what if I did this, what if I did that? Look, you have to leave that behind because it doesn't help. Let's stick with what helps. And that's a job the psychologist does very well.
And also getting into my specialty, there are many consequences of the treatment that affect the endocrine glands. Well, starting with infertility, in the case of chemotherapy regimens that can affect the testicles, in the case of men, for example, or also panhypopituitarism when there is radiation to the head and neck, thyroid. I mean, there are many patients who have to take hormonal treatment for life after chemotherapy or after radiation.
Yes, but you'll know that's the least uncomfortable part. Of course, it's the least uncomfortable because, well, nowadays you can avoid infertility because, well, you can preserve fertility first, whether the patient is male or female. And on the other hand, if you need hormonal support, then you receive it. Fortunately, maybe that's the least bad part, right? I think, in my experience, that the most uncomfortable thing for the patient is having to adopt a new routine to avoid these adverse events. Exercise. People who aren't used to exercising have a really hard time. Of course, when you explain and convince them, they just say, oh, doctor, but doing that makes me feel tired. Yes, but you're going to feel better the next day if you do this routine. It's just that exercise routine. Even if you're tired, you start doing it and gradually increase it. It helps a lot. Exercise has a direct relationship with reducing fatigue or tiredness, reducing sleep disturbances, reducing cognitive deficits, and reducing rumination. The one who's always thinking the anxious one, that's not it. People have no idea about the benefits of exercise, about the benefits.
You mentioned earlier that fatigue is also part of the effects of cancer, of the tumor itself, right? Yes, it's because of the inflammatory environment it creates.
In fact, fatigue, which is called cancer-related fatigue, is the most common adverse event caused both by the disease itself and by the treatment. And it's so common that now for the past 10 or 15 years, its study, management, and evaluation have become mandatory during oncology consultations. Because 20 years ago, it was understood and believed that this was simply, well, yes, are you tired? Well, you're just tired.
More psychological.
Right? No, it's like that. It's not like that. Cancer-related fatigue is a condition that is related to the inflammatory process itself, which is also perpetuated or worsened by chemotherapy treatment. And it's related to interleukin-6 and cytokines, and it causes a process of mitochondrial exhaustion in the muscle, constant inflammation in the muscle, which makes the patient truly feel tired. And it's defined as fatigue not related to any previous activity that would justify it. It's a subjective symptom and it's permanent, it doesn't improve with rest, and it can even become cumulative. That is, there are even patients who have been studied, women with breast cancer, men with prostate cancer. These are cancers whose survivors tend to live a very long time after treatment, and they still experience fatigue and feel tired. Now, nowadays, it is known that if you do aerobic exercise, that is 150 minutes of aerobic exercise per week, that means 30 minutes of aerobic exercise at a standard walking pace. One route, 15 minutes out, 15 minutes back. And out of those 5 days a week, in addition to those 30 minutes, you add 15 minutes for stretching exercises and 15 minutes for strength exercises. Of course, 90 minutes in the case of stretching exercises and 60 minutes a week of strength exercises help you reduce fatigue before starting chemotherapy and during chemotherapy. That is, you can prevent fatigue from appearing, or if it does appear, it will be very mild, and during chemotherapy treatment, you will help reduce that fatigue.
So the main and most important treatment for fatigue is exercise.
It has proven to be the most effective.
Of course. It could be the patient who thinks, how am I going to exercise if I can't because I'm tired? But it's actually the opposite. If you do it tomorrow, you'll be less tired.
Of course, but that's why it's so important to emphasize this during the consultation, for the nurse to be trained to explain it, for there to be a psycho-oncologist, and for the oncologist to insist on it. If you convince the patient, if you earn the patient's trust and convince them that if they stand up to do squats in front of the television, that's simply doing squats. Sets of 5 repetitions and rest, and another 5 and rest, and do that for 15 minutes a day. And you ask them again, and you keep in touch with the patient to encourage them to do it. Do you see the difference? Of course. I've seen it. I see it when I put it into practice. I mean, when my patients include it in their daily routine. Look, fatigue is also relieved if you avoid the contributing factors. Anemia is related to fatigue. If you improve the anemia, that's it. Anxiety, depression. It's also very closely related to pain. If you control the pain, then it decreases. If you already have all of that under control and you also get the patient to exercise, which has been shown to improve fatigue, you achieve an extraordinary benefit.
We haven't discussed pain, and I hadn't planned to ask, but many cancers are painful. I mean, there really are tumors that do cause pain, and sometimes the treatment for pain involves morphine or strong opioids.
We can leave that for another episode and talk about it later, because it really is a whole other sea of information. Pain is something else, and it's very much related to more advanced stages. When there are already compressions or complications, it's already much more advanced.
And another less known one is cognitive impairment. Is there a worsening of cognitive abilities in cancer? Yes.
There is worsening. It's what patients call brain fog.
What is that due to?
That pro-inflammatory processes mediated by cytokines, interleukin-6 increased CRP, is linked to a permanent process of inflammation throughout the central nervous system. That is the one responsible In addition, it is multifactorial as well as involving alterations in the hypothalamic pituitary adrenal axis and changes in the synaptic exchange between neurons. People mention it, patients mention it, and it is described loss of recent memory. People can't remember what I just wrote or what I just said. They don't have critical judgment in situations where they might have had it before. It's like a feeling of apathy towards what's happening. That cloudiness, that loss of interest in things that used to be interesting to them. If you used to like something, now you just don't feel like it anymore. And it's already known that it has to do with this inflammatory process, and it's not something that's related to anxiety or depression.
It's not just psychiatric, but also neurological.
I mean, that's right.
Neuropsychiatric. It has the biological part and the emotional part, which will obviously also have an influence. That's right. There's a topic that I think is barely discussed on the internet in this field. And it's how Gloria cancer affects personal relationships, sexual relationships, intimacy at home.
A lot. Do you know why? Because if people aren't okay with themselves, how are they going to be okay with everyone else around them, their family members, their loved ones, their partner, their children? The patient starts by feeling bad about themselves because they're in this situation. Also, the loss of control makes them stop feeling like themselves and stop feeling useful. So when they start to feel like a burden, like a nuisance, like they're bothering others, that's when the tensions start to show. On the other hand, the cancer patient who is receiving treatment starts to experience changes in their appearance. If it's hair loss, then it's hair loss or the adverse effects on the skin, which we haven't talked about but are also common. Weight loss. Or what would be, well, you reach a severe catabolic state where your clothes no longer fit well and you no longer feel comfortable. Those physical changes greatly deteriorate the patient's self-image. So just imagine how much more the patient would feel even more averse if their partner were to approach them sexually. The psychologist's approach to this process is very important here. If you as a patient accept and understand that you are seeing this as a toll you have to pay in life, I use this metaphor a lot with my patients. Imagine you're driving on the highway coming from Madrid to Malaga and you find out there was a detour you hadn't planned for. Okay, but there's a detour. So if you have a good car, good tires, you have a way to handle that detour, well, that's good. And if not, stop for a moment and find a way to get what you need. Whether it's food, water, or whatever you need to make that detour, make sure it doesn't distract you from your ultimate goal, which is your destination. If you have a partner, if you have children and you want to see them and stay connected with them, you want to see them grow up, teenage children you want to see graduate, or grown daughters you want to see get married. Hey, that's your goal or one of your goals. So don't let this get in the way of that or your relationship. And if you approach it this way or in so many other ways, there are thousands of other examples. That all this does is reroute you. It will probably be an uncomfortable path. You'll probably have to change your route, your routine, stay somewhere else for a while, but you'll get there.
Yes, that's it. I have a lot of questions. Do you think having concrete goals during the cancer process is important for survival? I mean, I've seen many cases of patients who hold on until their children get married, who wait until their daughter graduates, who wait. Does that happen? Is it important to have those goals?
Look, yes, I've seen it. It hasn't been studied, but I have seen it. I've seen patients who have a specific point they want to reach, but you see it much more in patients who have been in treatment for a long time or who already know their illness is terminal and are undergoing treatment. I'm not talking about palliative care, I'm talking about active treatment, but they know that this is going to come to an end. So that milestone, being able to reach that milestone helps a lot. Now, having a purpose and a reason for living is very important so that when facing this adversity, you can stay on your path. That has been studied. People who have purpose in their lives, who feel that their life has purpose, who have a meaningful connection with that purpose, whether it's spiritual, faith-based, religious, or emotional, they have a higher chance of coping with illness, responding to treatment, and surviving. In the end, that means they live longer than those who don't have it.
In other words, it's quite positive to have goals, whether they're work related, personal, or outside of the illness. We shouldn't base our entire lives solely on the illness. We should have interests outside of it.
Look, you have to have things outside of the illness because you are not the illness, okay? You are you, and this is something you have to go through and accept. But you are you with your own set of experiences and your goals to accomplish. But what I'm referring to is that life purpose that transcends, because this is an illness that has a strong emotional and cultural connection with death. Even if that's not the case, our mind plays a trick on us here. And that transcendent relationship between your own being and something beyond, whether you call it the universe, God, spirituality, or whatever you want. It has an event or a component, we don't know what, but there's one important thing, the way you approach the process. And we don't know why, but it has been studied, and it's known that people with that transcendent vision of their life tend to live longer.
Yes, yes, and with a desire to live. I wouldn't know how to link it mechanistically either because this can't be studied, but I know that a patient who gives up and doesn't want to live anymore accelerates the processes until they die. I mean, what I want to say is that when you give up, I don't know if it's the nervous system, the immune system, or what happens, but really that will, to live, as you say, keeps the biological processes functioning.
Yes, 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 yes. When you give up, it's uncomfortable to say, but yes, that's how it is.
And you've used an expression several times that the patient feels absent from their own life. What does this mean?
That the patient doesn't recognize themselves as the one who controls their life. That is, the patient generally doesn't verbalize it, you know? They don't know how to verbalize it, but they express it as, well, I don't recognize myself anymore. I'm not who I used to be. Me, Gloria, the one who used to work and do things, the one who was there. No, now I'm in a different situation. It's like, of course, there have been so many changes, or there are so many changes when the patient has it. When the patient has cancer, they no longer see themselves as the provider, the role they play, whether it's as a caring mother, as a wife who supports or communicates, or if it's as a successful executive or a purposeful entrepreneur. Well, patients describe all of that by saying, well, look, that's not me anymore.
Don't you think this has a lot to do, Gloria, with the label that society puts on cancer patients? Sometimes it's pity or seeing them as victims or feeling sorry for them.
You've hit the nail on the head. You've hit the nail on the head. Look, my view of cancer patients is completely the opposite, and that's why I'm here. I want cancer patients to stop being passive patients sitting in the treatment room like that, just waiting there like guinea pigs, like victims. No, no, not at all. I mean, this is counterproductive in every way. And this has a lot to do with culture, with personality, with education, with access to information. But we can also really cultivate a more proactive attitude ourselves.
and not a condescending one. Because look, there's always the overcoming adversity narrative. Now, with social media, there are always lots of cancer patients whom people, the public, label as heroes. But for me, behind that label of how brave you keep training and you have cancer and you keep working, there's a certain condescension. In the end, there's a hint of pity, yes. I think the patient senses that, and that's exactly what makes them not feel like themselves, but rather like a diminished version.
Correct. It's like they're being given special treatment. People don't like that, especially during this process. Look, I currently have a patient who's in his 70s and he works. Of course, he's an entrepreneur. He has his own company, his own business, but he works. He's receiving a complicated treatment. He has 3 synchronous tumors. It's not just one. And he knows that during those 3 or 4 days of chemo, well, he's going to be at home lying down and he starts watching Netflix. And then he recovers and keeps going. And on Fridays, he's with his friends eating Asturian beans. That is to say, it has a lot to do with attitude and perspective, but it also has to do with that concept that people have. Am I a part of this or am I an outsider to this? That is to say, can I contribute to making sure my life continues to be my own, or do I hand over control of my life to others? If you hand over control of your life to doctors, to your family members, to your partner, well, no. And that doesn't mean you shouldn't listen to the oncologist or to the advice of those around you. No, no, no. It means that you realize, I'll go back to the example, that this is just a detour. This is by no means the way you should operate for the rest of your life. This is a detour, and you need to accept it as such. Prepare yourself for it, get used to it, or adapt.
Yes.
And that's it?
Yes, and to shield your mind a bit from all those judgments and influences from society, right? Because for me, it's very interesting how culturally different illnesses or types of illnesses are judged differently by society. Obesity or type 2 diabetes is all about blame, right? Like you're a glutton and you're lazy and this is your fault. And there are a lot of judgments, right? That's where the body positive movement comes from. There are many attacks.
Yes.
With cancer, it's different. People pity you and think, poor thing. I don't want to put myself in that position, you know? It's like, poor thing, and I applaud you or give you that attention, right? Just because you're sick.
Or not, or they don't give it to you. Because if they did, I mean, just because of the healthcare system, if they gave you special attention, I don't know if they gave you more home care services or gave you tax benefits. I don't know. I mean, it's not really like that either. It's more of a condescending attitude, but in the interpersonal relationship and how I see you. That's it. That's it.
That's it.
Let's not say how you. No.
No, I'm not talking about the system or the structure of the system or privileges, but about how I perceive you. Correct. And that's also why many patients end up not saying anything about their illness out of shame about what people will say or how they will perceive me. And many patients carry cancer in silence or only within their family. I've known people who never said they had cancer until it became very obvious, right? And I think it's because of that judgment, right? I don't know what you think.
That has a lot to do with it, and I think, in my opinion, it has even more to do with fear.
Or fear.
Fear paralyzes. Fear paralyzes. The fear of what will come next. And I go back again to the idea that cancer equals death. When you make that change in mindset and help the patient understand with information that it's not like that nowadays in the 21st century and even less so in the first world, people die much less from cancer. People live much longer now. You're not going to live as if it were just a sore throat. There will be changes, of course. But you can live, and you can live on treatment for a long time. But a long time. Look, nowadays, when I was studying oncology, there was only one combination regimen of 2 drugs for lung cancer. And you knew that lung cancer, whichever type it was, received those 2 regimens for 4 cycles, and you knew it wouldn't last more than 8 months. In the best case scenario, nowadays and 8 years ago, 10 years ago, There are already dozens of treatment regimens, immunotherapy and combined chemoimmunotherapy and targeted therapies, only for different specific types of lung cancer, which range from 22 months to 46 months of survival, receiving treatment, that is, with a first-line treatment, and they can receive up to 2, 3, and 4 lines of treatment. When I tell you this, I'm telling you that the way cancer is managed has changed so much that it can no longer be thought of as synonymous with death. It just can't. And this goes against reality. And if we can change that mindset for the patient, their family, and society, that it's not like that. It's not like tonsillitis, but it is a chronic disease. Look, diabetes is a chronic disease, and like cancer, it isn't cured except in very specific situations. Hypertension is a chronic disease, and like cancer, it isn't cured. So if we look at it that way, fear becomes less paralyzing.
You would see it, I mean, you would always see it that way. That is, even if the patient is disease free and cured, as happens with many tumors nowadays. Would you still see the patient as someone with a chronic illness?
No, if the patient is cured, they are cured. And you don't know that until after 5 years. Okay. But if the patient isn't cured during, let's see, during the process while they're in treatment, until, depending on the stage, but assuming it's a stage that can be cured, the patient is receiving treatment. Until 5 years have passed disease-free, you can't say they're cured. So during that process, you consider it a chronic illness.
Right, but after that process, I do believe in removing labels, you know?
Of course, because if they leave the label on you, it's wrong, because that's not how it is.
Let's see. There's also the person who clings to the diagnosis, clings to it, not that they want it, but they base their identity on being a patient and on being an oncology patient. And sometimes it's also hard to let go of that. I mean, that doesn't just happen in oncology, but sometimes there's a clinging to the illness or to the identity that this new situation gives you. I support declaring you're cured and disease free since your additional tests are fine.
You're cured, you're Gloria,
You're Pepe?
you're Juan. And believe me, patients are much happier when they're cured. And what about that month or those 4 weeks that go by between getting the staging tests and going back to the oncologist every year to see how things are? Until you reach 5 years and are discharged, they're tense because people are afraid of going through this again. The patient is the most grateful that this is finally off their shoulders. But until you get there, accepting this with less emotional weight related to death, like you might accept diabetes or hypertension, helps a lot.
Okay, and Gloria, how do you support patients with your service? Tell us a little about how you work.
I train patients to receive chemotherapy.
You train them? I mean, is that how you say it? You train the patients?
That's right. I train the patients to receive chemotherapy. Well, that's how I explain it to my patients at the hospital. I treat them the way all oncologists try to treat their patients. And I take a little more time and use social media and my service to make it personalized. First, remove the mindset that cancer means death. And once that's addressed with rehabilitation, and you nurture it with information about the disease you have and the treatment plan you have, then comes the part of preparing them for the treatment. That means we're going to educate you about your entire plan, how many days you'll receive it, how many regimens you'll have, or how many cycles you'll go through, depending on each cycle. And this is closely related to how you're going to live your life now. And so that's accompanied by a third pillar, which is support.
They contact you when they're about to receive chemotherapy?
They contact me when they hear me and see me with a positive outlook on cancer. Well, what can I do? Okay, my service is for patients who are undergoing treatment. So my patients or patients who are undergoing treatment or who have already started and want to see a change in their treatment process, contact me and I prepare them for the next cycle. These are treatment cycles they'll go through hand in hand with me, changing their mindset and preparing themselves with information to avoid, modify, or minimize adverse events. And in addition to that, having me in real time for Gloria, what do? This happened to me. Gloria, I'm going to the hospital.
Tiempo real. O sea,
Look, that's how I work with my patients, and it has given me very good results. That a patient nowadays can write to me on WhatsApp and I can answer them like I've always done with my patients. I did it in Venezuela and I do it here. This happened to me. What should I do? You just do this or that and that's it. These aren't major consultations.
but very powerful.
Having
Simply for the peace of mind of having the oncologist on WhatsApp.
and knowing that what you're doing is the right thing. If you don't see her again until the next cycle, how do you know if she told you or not or what to do? No, it's just as she said, or you just keep going that way. Because this is a process of change. So support is crucial. That you feel supported by the patient, the doctor or specialist or the nurse. Look, I'll give you more. There is a study that has shown improved survival in cancer patients, and it was presented at the plenary session of the American Academy of Oncology in 2017. That was met with applause and awards because they categorized 700 patients with different solid tumors and connected them with a direct communication tool to the oncologist or nurse. So they could report the adverse event they were experiencing and ask what to do. Those patients who adopted that tool lived longer than the patients who were treated in the standard way. And why is that? The explanation in the discussion section of the paper is that the patient who stays on treatment is the one who has a good experience because they have minimized side effects. And that patient who has a good experience is the one who can either minimize them or control them or manage them. And that can be achieved with just a list of instructions. It's about being able to approach the doctor or the nurse and consult with them.
Yes, I really wish all patients had access to something like that, right? To such direct support. I remember when I was on call, patients would come in with toxicities, very anxious because they didn't know if they really needed to seek medical attention or not. The ones with milder symptoms or the more serious ones would come in desperate, wanting the oncologist to see them. And having a first-line tool like that, which allows you to filter many of those concerns, I think is very useful.
Yes, it has helped me.
So congratulations on that. What changes would you tell a patient who has just received a diagnosis to start making in their lifestyle? I mean, they say, I've been diagnosed, Gloria, with colon cancer. What are your first recommendations for changes they need to make in their life?
The first thing is to change your mindset. This is not the same as death. You had or have colon cancer and you're going to have surgery, or you've already had surgery, well, congratulations. They've already identified it, they've solved it, or they still have to solve it. Now let's move on to the next step. This is a transition, it's a process. It's not just opening the door and closing it. Secondly, you are the protagonist. The main character in this story is not the tumor. We're going to eradicate it, we're going to remove it, we're going to take it out, we're going to... No, you are the protagonist. Because you are a human being, you are the patient. So above all, let's think this way. Third, be careful with what you look up, read, and assume. Not everything is true. And look, I'm giving you all this advice and it's all psychological things. Psychological, emotional, but it's super important. And it's also what people pay the least attention to. People pay more attention to things like, well, what should I eat? Well, how should I sleep? How should I take things? No. Let's start here. It's very important for the patient to understand that you can get through this. Hope, yes, you can. Of course you can. There are so many testimonies that I have seen. It's not just that people have told me about them. I have seen them with my own eyes. In fact, I have a patient in Venezuela who has had stage 4 breast cancer for 17 years, and she no longer receives any treatment because she is doing wonderfully well. That is to say, it was put on hold and hasn't grown. Nothing at all. And she shares her story on my YouTube channel. And so many others, so many other patients. Of course, there are patients who suffer more, some who suffer less. I'm not trying to say that cancer can be cured. What I want to say is that during this process, you can thrive.
And many times it is cured.
And many times it is cured.
More and more, right?
That's right, more and more.
Thank you. Also, when we get this news, we sometimes tend to withdraw or isolate ourselves. How important do you think it is, Gloria, to maintain friendships and social connections, not just family, I mean friendship?
That has been proven. That has been proven. People who have connections, contacts, relationships, group support, who are constantly socially engaged have a different experience. I'm not only discussing the patient's emotional experience, but also the outcome. The outcome of their treatment and the outcome for their illness is much better. That has been proven.
And not just patient groups, which also have their role.
It's that your life goes on. I mean, this isn't Alcoholics Anonymous.
Of course, it's not like now I only hang out with oncology patients.
No, I go back again to the point about this patient of mine who keeps working, keeps playing paddle. He's a 70-year-old man who still eats his Asturian bean stew on Fridays with his friends. That is, people won't have the same routine they had before. But I tell my patients the following, and I prepare those who train with me to receive chemotherapy. Look, you're going to see that this is working for you, this training and this process, this support in this program. Because if you keep up part of your routine, which has now been affected by the treatment, you will be able to get back to your routine, at least 25% of it. If you used to go 4 Sundays a month to see your mother-in-law or your mother at home for Sunday lunch, you'll do it at least once, for sure. You'll do it. If you used to play moose 4 times a month or meet up with your friends to go shopping, have a drink, or go to the hair salon, you'll do it once a month. In other words, your routine, your everyday life, you can pick it back up.
And it's also very important that when friends get together, it's not just to talk about their illness. Oh,
No.
please, no. That poor thing label always makes it about how they're doing or how the test went. No, please. He needs people not to talk about his illness.
His life.
His illness.
Of course, that's why it's so important that the rest of us, those who don't have cancer, who don't work with cancer, or who have no idea about cancer, think of this not as death, but as a chronic illness. If you think like this, you're not truly seeing the other person. So, how do you feel? How are you doing? And you're not seeing them as if it makes you uncomfortable to get close, as if they were, I don't know,
Like they were an infectious disease. I don't know, like it was something.
correct. No, 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 no. Look, no. We need to change our mindset and let's start. Look, it's my job to start this with patients because that's why I study oncology, but it's up to all of us to change it. Absolutely, yes.
And most of the people who will watch the episode are not oncology patients. And I think that's a really good message. Also, changing and improving the perception people have of oncology patients. That's right, because that's also therapeutic for them. No, we shouldn't see them through that lens of fragility, right? Of feeling sorry for them, of pity, right? No,
No.
not at all. We just need to support them as we would with any other chronic illness.
Right.
There's a phrase, now that we're finishing the interview, that really struck me, honestly. I want you to explain it to us, which is how to go through cancer without letting it take life away from you while you're still alive. How to go through cancer without letting it take the life out of you while you're still alive, which is kind of the summary of everything you've talked about, right? I think of your approach.
The main point here is that you remain the protagonist.
Very good.
When you are the protagonist, you continue living your life, you continue being the center of the whole approach. For everything related to this situation, regardless of what you have had to go through, and you keep living whatever comes your way. Because someone who doesn't have cancer can go out on the street and get hit by a car.
No doubt.
Someone who doesn't have cancer might suddenly get a viral infection, or we go into a pandemic, or they get on a train and have an accident. Let's see, is death there? for all of us, because we are all human beings and we are alive. So, to the extent that you understand that it's also in your hands to live your life the way you've been dreaming, you will continue living.
I've come up with one last question that was totally off script. Let's see what you think. Gloria, do you think that after seeing so many cancer patients, cancer can bring positive things to people?
Oh, what a good question. And they're going to say to me, "Are you crazy?" But yes. Yes, because I know many people who nowadays say, "Wow, I'm a different person after having gone through this transition." And having already been cured or already diagnosed as survivors or not, or still having cancer. Look, I can't forget the image of a patient I met through the Spanish Association Against Cancer who still had active lung cancer. And she was explaining to all of us who were there, who were not cancer patients, how the disease had made her see life in a different way and with a new perspective. And that her purpose in life came from the illness she had. So that people would understand that life is not this constant rush. That life means that you are willing to receive, to be content with what you have, to see the positive side of what's happening to you. And that's coming from a woman who has been in treatment for lung cancer for 12 years.
That's a lot.
Well, I hadn't seen it.
Yes. Of course, that's my perception too. I think that sometimes illness, and specifically this one, awakens that spiritual dimension we have that's completely numbed or hidden under the rug.
Of course, because do you know why? Because it makes you set arrogance aside.
Totally. It's a real wake up call about life, right? No, this is life, not all that other stuff.
Correct. It's just that our human nature leads us to be arrogant, boastful. You know, like we think we're above good and evil. And no, we're not. We're not. Now, this, like any other change, shock, or pandemic, can give us an important reality check. But if you assume that you are the main character in your life, I'll say it again. This works out. It works out and you get a good result.
So, with that message of hope, we're going to end this talk, which I swear I loved. I really enjoyed it. I'm very happy. Very natural. You communicate very well. And I hope your message can reach a lot of people and many patients. Amen. So, I'll leave Gloria's contact information in the description and the pinned comment so that, well, if you need it, you can contact her without a doubt. Thank you. This is your home, and our platform is always available to you.
Amen. Thank you.
Thank you guys for this episode. I also think it's going to give you a very different perspective on cancer, whether you're a patient, not a patient, a family member, whatever. And that's it. See you in the next one. A big hug, and let's keep empowering people.